Good afternoon. My name is Jaesung from Korea University Chungju Hospital. It's a great honor for me to speak here at this conference, and I would like to take this opportunity to speak about reimplantation surgeries for DBS electrodes. And this is a single-center experience from the Cleveland Clinic. According to Dr. Andros' report, there were 47 centers in North America where more than 25 cases of DBS had been performed by 2005. And by 2008, according to Medtronic's clinical database, 150 centers in the United States do perform DBS. And worldwide, the number of DBS cases has been increasing exponentially. DBS has been known to be safer than thalamidotomy or palidotomy, but unfortunately, and of course, it's not without complications or unsatisfactory outcomes. So, at some point, we need to deal with one of these unsatisfactory outcomes, and yet, we still do not have a consensus on the following. First of all, the definition of failed DBS, indications for revision or reimplantation, and how to deal with referred cases. So the goal of this study is to share and present our experience over a decade so that we could reach the general consensus sooner than later. Among over 800 DBS electrodes implanted since 1997, we selected 450 electrodes for 270 patients who underwent DBS surgeries between 2004 and 2008. We excluded IPG revision only or extension wire revision only, or just simple removal of brain lead without reimplantation. This diagram is about the causes of reoperation between those who had the initial surgery at the Cleveland Clinic and those who were referred. Among 44 reimplanted electrodes, 14 were referred from multiple centers, and 11 of these 14 were misplaced leads. On the other hand, the most common cause of our center was hardware break, followed by infection. This graph is about which surgery required a new microelectrode recording and which didn't. We categorized the whole cases into 4 groups: misplacement, migration, infection, and hardware break. Every reimplantation for misplaced, migrated, and infected lead was performed using a new microelectrode recording. For the broken leads, we basically do not need a new mapping unless they were referred, which means we do not have the coordinates, or they were aimed at a different target. I'll discuss these 6 cases later. And this graph is about a single replacement surgery versus stage surgery. All of the infected and most of misplaced leads were removed first and reimplanted at a separate surgery in a staged fashion. Broken leads were replaced at a single surgery, but again, 9 of them were reimplanted in a staged fashion because 3 of them were referred and 6 of them were in a different target. So why did they need to be reimplanted at a different target? Because they did not benefit from the initial surgery in the first place, even before the hardware break. And what's interesting here is 5 of these 6 cases were for dystonia patients, and we assume that their uncontrolled neck motion that did not improve after the initial surgery led to the hardware break as well. And how long did we wait until we put the new lead in since the removal of the initial one? The misplaced leads were reimplanted in 5 weeks after the removal, and it took much longer for the infected leads, 29 weeks, because they needed to be treated with IV antibiotics for several weeks. And these infected leads were reimplanted most frequently between 10 and 20 weeks after the removal. This diagram is about symptomatic improvement after the reoperation. 100% of STN DBSs for Parkinson's disease resulted in good symptomatic improvement. On the other hand, I would like you to take a good look at red sectors on each side, which represent dystonia. Among 9 reimplanted electrodes for dystonia patients, 4 of them did not benefit from the second surgery either. And these 4 accounted for 80% of unsuccessful reoperations. discussion. In terms of surgical techniques, we could grossly divide them into two. A, stage surgery using NER, and B, single surgery without NER. Misplaced leads, infected leads, and refer cases were reimplanted using a new microelectrode recording in a staged fashion. The broken leads were replaced at a single surgery without using NER, unless they had had a suboptimal benefit even before the heart break. For the refer cases, we always try to get pre-op coordinates and post-op CAT scan, but it's not always possible. And any surgical decisions should be preceded by a thorough reprogramming by an experienced medical staff. Because as a matter of fact, many of suboptimally functioning electrodes were reprogrammed in our center to function optimally without having to undergo a second surgery. Dystonia deserves a special attention. Would you take a good look at the red sectors that represent dystonia? Among 800 total cases of DBS, less than 9% were for dystonia patients, and it accounted for 20% of reoperation cases and 80% of unsuccessful reoperations. You could clearly see a disproportion here, and one of the possible explanations would be the wrong indication in the first place. We all know that DYT1 gene positive dystonia is well responsive to DBS surgeries, way better than other forms of dystonia, but I don't believe